Good morning, good afternoon, and indeed good evening from wherever you find yourself around the globe. I hope you're both safe and well. My name is Tim Lane, and I'm the editor of Surgery International. Surgery International is an online surgical community linking 20,000 surgeons worldwide over 140 different countries. It's a free-to-access site, and we share news and good practice from around the world. Our news items focus on surgical practice, innovative technology and robotics, as well as lifestyle issues affecting the surgical community, everything from surgical burnout to resilience. We also celebrate the significant contribution of some of our surgical leaders with in-depth features which give a candid behind-the-scenes look at both their professional and personal lives. With me today on screen from Surgery International is my friend and colleague, Professor Shafi Ahmed, who's our medical director. And behind the scenes is our commercial director, Andy Buchanan, and our marketing director, Julia Price. So you can give them a wave, but they won't be able to wave back. Today's webinar is the second in our Talk Surgery series, and it's going to focus on sustainability in healthcare systems. Before I ask our panel to introduce themselves, I'd first like to thank our sponsors, who are the Royal College of Surgeons in Edinburgh, Oroscoptic, and of course, JAV Medical. So let me first allow our panel members to introduce themselves and tell us a little bit about their particular interest in sustainability. Should we start with you, Addy, first?
Okay, thank you. Thank you for having me. So I'm Addie McGregor. I'm the Sustainability Manager for ABHI, which is the Association of British Health Tech Industries. So essentially, we're the trade association that represents medical devices, diagnostics, and digital health. So very much on the supply side. And so I work closely with our members and the rest of the ecosystem on trying to make the whole sector more sustainable.
Fantastic. Lucinda.
Hi, my name's Lucinda Cruddas. I'm a vascular trainee in London. I'm currently doing a PhD at UCL, and I have a special interest in sustainability in surgery, and I'm a champion for the Royal College of Surgeons.
Fantastic. Ingo.
Hello, good evening. My name is Ingo from Jones AV, JAV Medical. I'm the managing director, and we've been looking into how to make technology more sustainable for operating theaters and surgery. With increasing use of technology, there's increasing impact on environment and sustainability. So we've been looking at how to optimize things.
Fantastic. Anil, would you like to tell us about yourself?
Good evening. Nice to see you. Anil Bangi. I'm a consultant colorectal surgeon, and I'm a professor of global surgery at the University of Birmingham. And my remit here is really around research to underpin what I call innovation and adoption cycles. So it's behavioral change, and it's bringing a broad lens to research to underpin sustainable surgery.
Fantastic. And last and definitely not least, Shafi.
Hi, everyone. It's Shafi Ahmed. I'm a consultant colorectal surgeon in London, and I'm medical director of Surgery International.
Okay, so let's make a start. So when we talk about sustainability in healthcare systems, really we're only talking about three things: the costs of healthcare provision, the resilience of healthcare systems, but also increasingly environmental stewardship, which will be largely focusing on this evening. So I'm going to turn first to Shafi, who I think is pretty much embodies what you'd expect from a global surgeon, and ask him to give us if you like, a world view on the impact that global healthcare systems have on carbon footprints around the world. So Shafi, sum up if you can where we are today.
Thanks, Tim. And how exciting is it with wonderful world leaders in sustainability in our practice of surgery? I want to just zoom out a little and look at the kind of broader view of why it's actually important, why we're actually discussing this very topic that's become quite important over the last few years. Well, let's look at it. If you have climate change and you have increasing temperature globally, that's heat, of course. What does that impact in the world? It causes lots of morbidity. For example, by 2040, if the temperature carries on rising as at the moment, there's evidence from WHO there'll be 125 million more people with health issues due to dehydration, heat stroke, and cardiovascular disease. Also, of course, the increase in pollution. that leads to increasing respiratory disease. And with that, of course, there'll be more natural disasters. So there'll be more trauma for us to deal with as surgeons. So the impact is going to be overwhelming if we don't adjust and manage this rise in global temperature and think about climate change. Of course, that leads back to sustainability. Another fact that I came across was that by there's going to be 53.7% increase in mortality just due to heat by 2040 in over 65-year-olds. So that's got a huge burden of problem for the healthcare systems to adjust to. That's why important we have to do our little bit. What about surgery? Well, actually, the Royal College of Surgeons of England quite recently looked at this and produced a report only a couple of years ago. The NHS, as you know, large organisation, it accounts for 4% of the UK's footprint of carbon. And that's due to the travel-related areas, infrastructure, and waste management. From waste management perspective, surgery makes up the vast majority of that. Up to 70% of the total hospital waste is from a surgical operating theatre. That's considerable, leading to lots of emissions, and therefore will impact, of course, our footprint. So the RCS actually signed up in 2023 to the Climate Emergency Declaration. So they declared that this is an emergency for us in healthcare, and all the colleges signed up to that same policy, showing that we now need to deal with this as an organisation at the Royal College and, of course, other industries. They've also pledged support to the 10 commitments made by the UK Climate Change Authority. The NHS, of course, is committed to net zero by 2040 or 2045. That's 5 or 10 years. For the UK as a whole is going to be issuing its kind of net zero policy. As we know, that's a global phenomenon. So we have our own concern we have in surgery. It's a huge waste problem that we maintain. And the question is, how can we do better? Do we start thinking about it? Do we think about how we adopt change? How do we use processes that allow us to reduce those emissions? And this is why it's so exciting to discuss it today. Hopefully between the panel here, we'll find some potential solutions, examples of good practice. We'll also look into the future of how we as surgeons and that community deal with this global problem.
Yeah, so we're going to be covering all those. But from the outset, do you think sustainability is an issue just for countries with very advanced healthcare systems? Or do you think it equally applies to healthcare systems in the developing world?
So that's a fundamental part. Obviously, the people in the developing world will be affected much more because of what happens with climate change, that they, of course, don't have the reserves or resilience in healthcare systems to deal with the increase in morbidity and mortality, and of course, things like these events that happen, like hurricanes, for example, storms, etc., which will add impact to a healthcare system. So ultimately, what we do in the West, for example, in the UK, will affect much worse people on the ground in the lower and middle income countries. And that's kind of a concern we have in a global perspective. And we have to do a little bit, if you like, to adjust, ensure that we're equitable on a global level.
That's fantastic. Thanks. That sets the scene very nicely, Shafi. Anil, if I can turn to you first. Surgery has a very high carbon print. It's okay, we're surgeons, we're used to being blamed for everything, but we're obviously the bad boys here. Can you go through some of the reasons why surgery has a particularly high carbon footprint in healthcare systems?
Good question. So number one is system boundary, and we should all get used to this term of system boundary. With anything sustainability, you've got to draw a line somewhere. So you've got to draw a line about whether where you're going to stop counting the carbon. So as surgeons, the first system boundary are the four walls of the operating theatre. So in those four walls of the operating theatre, it's the most energy intensive area per foot of the hospital. Heating, lighting, equipment, staff, drugs, anesthesia, gases, etc., etc. So just within that environment, the energy used per square foot is extremely high. And then you can push the system boundary wider if you want to. And the next, beyond energy and beyond what happens there, waste is the next one. So waste is, there's an extremely high burden of waste coming from an operating theatre. The carbon burden from that is quite low, actually, comparatively to things like energy, but it's worth commenting on. And then push your system a bit wider and you get into the supply chain. If you think about how many sutures we use, energy devices, and do you know the average amount of, what's the average time one of our devices has been around the world before it gets into an operating theatre. But like a suture, an average suture has, been around the world at least 1.5 times before it gets into operating theatre. So where's the metal come from the stitch? Where's the material come from? Where it's been put together? How's it then got into operating theatre? What's the supply chain? So supply chain is the next big burden. So as one of the questions I get asked often is, what do I do tomorrow? So one of the questions you've got to ask yourself as an individual surgeon before you address the system is, where do you want to draw your boundary? So as the conversations develop this evening, and I'll stop, number one is think about what happens in your operating theatre and what you can control. And then number two, think about what's going outside of your operating theatre. Number three, then we deal with the supply chain and the energy coming into the operating theatre. Those are harder. We need different people to solve those problems.
Okay, that's very interesting. I hadn't realised the suture I use is almost as well travelled as you, Sheffy. But many, Anil, many surgeons will say, perhaps unfairly, they'll say, look, hey, look, I've got enough to worry about. I'm worrying about patient outcomes. I'm worrying about everything else. This is just something else on my plate, as it were. But what practical things can people going into theatres tomorrow, or thinking how they're going to manage their theatre time over the next few months, what are the practical things that they can do to make a difference tomorrow, next week, next month?
Good question. And I'm a practicing surgeon, so I don't compromise on my patient care. It's a false economy. If you do something and you say, well, it's better for the environment, but there's going to be an increase in wound infections, that's a false economy, because the wound infections create ever such a lot of carbon. So number one, I don't compromise on patient care. Underpinning all of this are good, safe outcomes for patients. That's number one. Number two, then what I've started saying to people is, look at what you're doing as an individual first. Look at how many times you're eating meat and what meat are you eating. If you're lucky enough to be able to afford an electric car, are you going there? Look at your international travel. Do you really need to be making the trip? And so number one, there's what you're doing as an individual. Number two, there's what you're doing as an individual and team within the operating theatre. So tomorrow, if you open that drawer for the gowns, and you've got the choice between a reusable and a disposable, why are you choosing which one? Do you have a belief there, or do you like the way the single-use gown smells? Because that's not a good reason to use one. In for example, Shaffi and I do colorectal surgery, and I think I would hazard a guess that we both say the gown is not the primary driver of wound infections. So in that type of surgery, choose the reusable gown. And then you've got the option to open things and not open things that you don't necessarily, don't open too much. Equally, Tim, I like to have a 3.0 PDS ready for those emergencies. I don't want someone mushing around trying to find it. I like it on a needle, ready to go. So there's an absolute balance.
Yeah.
So those are the things you can do immediately, and the system stuff I think will come to you later.
So I mean, there's a sense that we're sort of reinventing the wheel, and things are going, we've gone backwards a little bit. If you're as grey as me, I can remember going into the theatre for the first time, and there were no single-use gowns. There were no single-use instruments. There were always scrubs which were recycled and returned sterile the next week. So perhaps part of this is us just remembering what we used to do well in the past.
And there is an element of those interested in this topic, and for your viewers watching tonight, about behavioural change theories. And as surgeons, we really need to have better education into behavioural change. Why do people do things? Why do they stop doing things? Why do things go in cycles? And then what are the opportunities and motivations to change those cycles? Because everything does go in cycles, and that's well beyond the operating theatre. It's on the roads, it's in the shops. So to start intervening in these areas, we need an understanding of behavioural change theory.
That's fantastic. Thanks, Anil. I'm going to move on to Lucinda now. So, Lucinda, we've heard about some sort of practical measures we can do to reduce surgical carbon footprints. But of course, there are other ways to affect that change as well. Things that you've been interested in about surgical care pathways, reducing the need for surgery. Would you like to sort of talk us through what some of that involves and your interest there?
Sure. So the best way to reduce the the carbon footprint of the operating theatre is to reduce the amount of operations that are happening. And again, this needs to be balanced. We can't not operate on anyone. We need to operate when appropriate. But it starts really with the public and public health, and preventing or reducing the progression of diagnosed diseases and surgical disorders, which starts with addressing things like obesity, because we know that obesity is associated with gallstones, with hernias, with cancers, and addressing things early on. And that also applies to things like diet, lifestyle, smoking, trauma, HPV. The list goes on, but really, by starting by addressing public health, we can stop things before they progress. There's also a huge amount of regional, international variation in diagnostics, medication, surgeries, follow-up, and this creates, like I say, variation both nationally and internationally. And expanding from that, as we've already mentioned, the difference between the developed and the underdeveloped world, the variation is vast. And we know that in the underdeveloped world, there are billions of people who don't have access to safe surgical care, leading to preventable deaths. And we need to increase surgery in those areas and make sure that need's being met, and make sure that by increasing the surgeries and meeting that need, they also incorporate sustainability.
Okay. Do you have any examples where there has been sort of a measured metric for changing sort of carbon footprints by changing care pathways?
So the surgical care pathway is, it's complex. It's many steps. So we go from the outpatient, seeing the patients, preoperative care, perioperative care, postoperative follow-up, discharge. From as I'm aware, there's currently nothing that has seen everything all the way through, but individual hospitals have looked at each step of the way, and currently we're at that stage of more making small changes to kind of address single areas rather than build up all the way through in the surgical field.
But I guess it's again when people are asking, well, what can I do about this? I'm a surgeon, I'm just doing my job. It's something in small parts you can contribute to any care pathway, which will ultimately, small gains will impact on the overall environmental aspects of these things. So thank you for that, Lucinda. But that's another way of looking at things rather than just switching off the lights in theatres at the end of the day. If I move on to you now, Addy, clearly sustainability is an issue for the wider healthcare community, and you're a good example of that. What do you think health technology companies and other suppliers can do to contribute to improving sustainability within healthcare systems?
So there's obviously a huge number of things that they can do. And when we talk about sustainability, there's different aspects we can talk to about it. If we stick more to the environmental piece, as is in the NHS Net Zero Supply Roadmap, as of about 2 weeks' time, all organisations that are supplying to the NHS will need a carbon reduction plan and looking at what their emissions are in-house. So in terms of the impact and resources they use to go into these products, they're looking at how to reduce them. They can think about where they get their energy from, how the materials are made, what they're doing to reduce the waste in-house as well, which can also drive down the cost. In terms of when it's already in the healthcare system, circular economy and what we're doing products at end of life is very, very much on the minds of everyone at the moment. There's a big piece of work with the Department of Health and Social Care called Design for Life, which is specifically looking at supply resilience and efficiency. And what's been great about that is the sheer number of different stakeholders that are involved in that programme, because it does take a huge number. And there are organisations that are looking at collecting their products and trying to recycle them. But actually, talking about sutures, Johnson & Johnson have just started a programme recycling those within different hospitals. I think it's quite small at the moment, but the aim of it is to grow. And particularly a growth in refurbishing surgical instruments, so collecting them and not just throwing them away once they've been used once. And there's a number of different organisations in the industry that are using that and growing in size. And
I think one of those that you're involved with is ReMed and Loughborough University. Tell us a little bit about that.
Yep. So ReMed stands for recycling medical devices, very much. And that is thinking specifically about smaller devices. So they described it as things that you can carry in your arms, I think was the definition of the size. And again, that is a project that's trying to bring together the academics that are doing a lot of the research in-house with the industry that will hopefully utilize these things. And then also the healthcare system, because there's so many different factors to it. You need to make the device, make sure it's commercially viable, make sure that it meets regulation. That is probably one of the biggest challenges that we face is, as Anil said before, patient safety is at the top of everything. So we can't quite do the same things that other sectors can do.
Yeah.
But yeah, thinking about what we're doing more long term and moving, as was said earlier, more towards how things were.
So can you tell us a little bit more about, because many people won't know about the sort of NHS net zero supplier roadmap, but what does that involve practically? Is that something that's compulsory? Is that something that's voluntary to sign up to?
It's compulsory. So if you are supplying to the NHS, you have to follow this roadmap now. It came into effect a few years ago, and it's different milestones from 2022 up until 2030. And there is now a minimum weighting of 10% towards social value related questions in every single tender across the whole of England. It's predominantly England, Scotland and Wales doing slightly different things. And then there's been the gradual introduction of carbon reduction plans over the last year. And also if you're now supplying to NHS supply chain, which an awful lot of suppliers are, I think it's about 60% of all things that are procured for the NHS in England go through there. You also need to complete the Evergreen assessment, which is an extensive tool that asks organisations what they're doing beyond the mandatory ask. So it's mandatory to do it if you're on the supply chain, but it's more them collecting information about what organisations are doing and how they can work collaboratively to move forward. So all organisations should be measuring their carbon emissions in-house and committing to what they're going to do over the next few years to change it and to reduce it.
Fantastic. Thank you very much, Adi. Ingo, we were chatting the other night, and you're in a unique position in being able to compare the approaches of two different healthcare systems as they try to address sustainability issues. And you can perhaps see the difference between a Norwegian approach and the approach in the UK. What do you think the differences are, and why the differences in success?
Well, I think there's the different areas that you can look at. You know, you have on the one hand the operating theatre, the technology inside. You have the public health aspect of it, the recycling aspect, and supply chain issues. So in a country like Norway, which you know is very rich and has a very advanced health sector, you have very modern hospitals that are trimmed to be energy efficient, and you have you know, a lot of electric cars and a very thorough pledge to reduce travel, and you know, things mirroring the net zero 45 roadmap of the UK. They have, you know, traditionally started a little earlier because, you know, Norway is the country that has the most electric cars per capita in the world. The electricity is made from hydroelectrics, so it has very little carbon footprint. So, and then that reflects, of course, public health with higher than average incomes. Though when you go inside the, say, the operating theatre, as Anil said before, you look at the boundary that affects surgery directly, it's not very much different than in the UK or actually any other countries that we work in. And that comes to the behavioral change and the good practice ideals, you know, in where do we start? You know, as you say, switch the light off in the evening, but then there's bits where there is equipment that people forget to switch off or don't switch off. And then there comes the question, how do you utilize technology to support the good practice and the behavioral change that you want to achieve?
And do you think that drive is government driven, or do you think it's just a cultural norm in Norway where people sign up to this sustainability issue because they've been used to getting clean electricity and the like? But where do you think that drive comes from?
So Yeah, that's a good question. I've always looked. I'm German from birth and grew up over there, where there was traditionally a long time back already a lot more environmental awareness in terms of recycling, energy use, and a lot of issues around that compared to the UK. So it's hard to pinpoint where that comes from. I mean, it's good that we now have across the board a drive from governments, to pledge towards net zero and to bring in regulation to bring about that change, and maybe behavioral change starts with training and education. And in countries alike, the education part, has probably started way earlier than here.
So I'm going to put you on the spot unfairly, Ingo. So the NHS net zero aims by 2040. Do you think that's achievable? Do you think that's realistic?
So I think yes, yes, I think it is, but it needs action now. So a lot of things in surgery, if you look at building a hospital or acquiring technology and equipments that are in use in hospitals, they are purchases that need to last a long time. They're expensive equipments, they need to last, and therefore they have a long-term impact. So if you want to achieve those changes by those target dates, and it's not just the 2040, it's the major reduction of output that the NHS has direct control under. And if you want to do that, we need to start now, and we need to have the awareness and the willingness to go, yes, we need to commit now.
Yeah, I think it'll be interesting to see how other health systems fare. I think there's a couple of private providers in the United States who have committed to net zero. I think Western Health in Australia has committed to net zero by 2030. So it'll be interesting to see how different healthcare systems address this. Annie, if I come back to you, I mean, you touched on one of the big contributory factors to carbon footprints is, which is energy in hospital settings and things like that. And so clearly the issue comes up as, given that that's the largest proportion of the carbon footprint, what is the role of renewable energy sources in healthcare systems around the world, solar power, etc.? Have you got any thoughts on that, or any examples where that may have worked well?
Well, I hosted a meeting today for health and education sites in the West Midlands. So the West Midlands in England has a population of 5 million people. It's a small country. And the question is, how can we learn from each other and connect upon energy strategies? So Tim, indulge me for a moment. To answer your question, you need to split it up into what's going on in high income countries like the UK, what's going on in low middle income countries. So in the UK, 50% of our energy is already supplied by renewables. But we need to do much more, because the further transition for that is going to be a challenge for everyone. And it's fractional gains. Everyone needs to do their bit. So some hospitals are starting to make the journey installing solar farms, but it's hard work. And the learning's being lost. So everyone's starting again. Everyone's trying to find their own way. So the solution for the individual hospitals is to have solar over the car parks. It is to install heat pumps. And we'll get there through the UK's decarbonisation scheme. But there are two questions there. Number one, how can we accelerate it? Number two, how can the hospital, which is the leader in the community, wrap in the GP practices, wrap in the schools, wrap in the universities? So that's the mission in the United Kingdom. In middle income countries, it's a very different issue. Our latest census has identified that 9 out of 30 days worth of operating are lost in low middle income countries due to power losses. When power losses do occur, diesel generators kick in, and diesel generators are as bad as you can get for local environments and the global environments. So actually the environments around these generators, people are subjected to very dirty air. So you've got a double hit of clean and reliable energy lacking in low middle income countries. So in those settings, again, where hospitals are vanguards for communities, we need to accelerate the installation of solar energy. And Tedros identified that this could be done for every healthcare facility in the world for a mere $5 billion US. but actually setting off on a journey, negotiating through people and getting there is a major challenge. But as a network of surgeons, we have a unique opportunity because surgeons are present in virtually every major hospital. Surgeons tend to be relatively permanent fixtures in hospitals. And in the middle income countries, for example, they can reach very easily to the management. So they are agents for changes. And one of our missions is to see the surgeons in these hospitals lead on the mission to install clean and reliable energy, because you can't really perform an operation without energy.
So, as you say, the value is £5 billion. It's a relatively small amount of money in today's world if you think what we're spending money on at the moment. Is there any real hope that developed world with more advanced healthcare systems, is there any links between the two that will help those in developing worlds to improve their energy supply? Is there any sort of World Health Authority or anything like that which will help them?
There isn't. The only combined currency, in my opinion, and this is why I'm here, will be the surgeon. Because in each health setting, like if you look at the UK's NHS, clean energy is always fifth in the priority list for the NHS average financial officer, which always means that they've got to deal with the top one or two, the ambulances at the front door, the elective waiting list, the long waiter. And then, so day to day, no one's getting there to the energy supply, to the solar farm, to the heat pumps. Equally, same in the low and middle income countries. There are other problems pressing there: the finances, the payments, the emergencies. So who's creating the day-to-day headspace for this? So actually, if we and you and your global audience can unite, we can actually be an agent for change and push the agenda for solar installation. So we have a network of 100 hospitals in 7 countries, 100 major hospitals in 7 low and middle income countries. So we're going to set off on a journey to seek ambitious, to seek £100 million to totally decarbonize those hospitals. And by decarbonising the hospital, we're going to, at the same time, decarbonise the school next to the hospital and the telecommunications masts around the hospital. So that's a huge ambition. And to the average surgeon, you say £100 million, and they say, well, that's not cheap. But then, Tim, you identify the total cost is £5 billion. So actually, what we need to do as a community is go forth and find that money. So it's a huge challenge, but there is part of me to challenge you all back that this climate change is an emergency. We are going to see a hot summer in the UK, and we are going to stop doing operations as a result of it. So we need bold measures. We need people, Shafi, we need people there saying we need to find £100 million to install solar into major hospitals around the world.
Well, I'm pretty sure, Anil, if anybody's going to do it, it's going to be you. I've absolutely no doubt in that. Lucinda, if I come back to you, can I ask you to change your hat? I want you to take off your academic hat now. I want to put your vascular surgery hat back on, and I want you to tell us a little bit about your role as a sustainability champion and what that involved. Because really, what I'm looking at is because when people talk about sustainability, and when I was talking to them at work today about it, most people say, "Well, yeah, but what can I do about it?" Yours is quite a practical role here where everybody could do something similar. So tell us a little bit about your role as a sustainability champion.
Sure. So as we've established, leadership is one of the most important factors going forward, and that can be top down or bottom up, and bottom up is what the champions are. So the Royal College held a position to apply for as a champion, and in the end, they accepted everyone who applied because from their perspective, if anyone is passionate about making a change, let's create this community together. So we met at the Royal College, and it was real brainstorming of ideas, sharing experiences, because one of the major things as a sustainability champion that you come up against is a lot of resistance to making change. You can make presentations in your department, in your hospital, and it's very hard to sometimes translate that into change in behaviours and individuals. So the idea of the champions is to share ideas, to share experiences so that you can take that back to your hospital and try and progress those changes. And then it creates the network so that as part of training, we're moving around hospitals all the time. But when you have that network, you can share your experience, what you've built up at your hospital, and hand it over to someone who's coming into the hospital. So it really adds some unity in the sustainability fight, which can feel a bit fragmented sometimes.
Presumably the role, although this is run by the Royal College of Surgeons, but presumably this is a role that anybody could do in any country, in any hospital. So people who are sort of watching this webinar from further afield, presumably they could take on similar roles. Is there any sort of suggestion that you're going to try and link up with people from abroad to make a wider community, or is that something you'd like to do in the future?
I'm sure that would be very welcomed.
Yeah.
And in the NHS, every trust has, you know, a green community. So even if there isn't that opportunity in different countries, there will be undoubtedly be a community within the hospital that you can link up with. And it's really good as well to join forces with other teams. So, you know, talk to someone on intensive care, and you can run similar projects, be it the plastic specimen bag that you put your specimens in, reducing the use of those. So there's a lot between departments that you can share within your hospital, but definitely to reach out internationally would just be another benefit.
I think that would be fantastic. I'm sure a lot of people would be interested in that. Adi, if I come back to you and just a sort of a rather sort of broader sort of question, what do you think industry's biggest challenges are going to be for, you know, in the medium to long term in terms of sustainability?
Sure. I think touched on it slightly earlier, but regulation, partly from the angle of patient safety, and that's just the top of everything we have to do. But also how long it takes once you make a significant change to a product to go back through the regulatory process and how much that costs. So even though there are organisations that are doing things now, their product isn't safe to use now in terms of the way that the regulation sees it. So that can be a challenge. And another thing that we're talking to the MHRA about a lot at the moment is electronic instructions for use, and that move over to that, which hopefully is a relatively straightforward, easy win. Obviously, it's a lot more complicated than it sounds on paper. Horrible pun, sorry. And yeah, so regulation is a big component of that. I think as with everyone in the ecosystem, it's been a big learning curve, and that in itself is a bit of a challenge. So meeting these requirements for the net zero roadmap, in order to complete a carbon reduction plan, you need to know what carbon emissions are, what scope 1, 2, 3 emissions are, how you measure it, what you can do about it, all those sorts of things. So I think, and finding the time to be able to do this. We're an incredibly SME heavy industry. It's between 80 and 90% SMEs. So there's time, there's resourcing, there's funding, there's finding the expertise in-house. And we're making significant strides in all of these areas, but it just is quite challenging. And I think the landscape in itself within health tech in the UK, sustainability aside, is also quite challenging. So there's just something.
So, I mean, you talk about the landscape, and obviously the landscape is a worldwide landscape. Do you get a sense of industries across the world, whether they're all signed up to this pathway? Because obviously different countries will have different rules. But do you know? But they tend to sell to an international community. Do you get that sense that most people have signed up to these issues, or are there still companies that might use it as an advantage in terms of cost cutting and things like that to avoid them?
So I think certainly globally there's a lot more alignment, and we're seeing that continually. I know that the NHS centrally are doing a lot of outreach from their sustainable procurement team and Green NHS, but also in terms of for our industry, we're trying to work more collaboratively for sustainability as well. There's, I want to say about 17 different health systems that have committed to being net zero, and so many more that are committed to reducing their emissions and mitigating their impact. And we know that there are other countries are also looking at what the UK is doing, and specifically the NHS and its net zero roadmap as somewhat of a blueprint. I've presented to a number of our international organisations to tell them about it. In Australia, there was recently a recently a government consultation that quoted the NHS Net Zero Roadmap, again, as a potential benchmark for how things will go. The NHS have signed an agreement with HHS in the States and committing to aligning with them. It's growing globally, and I think everyone is on the same journey. And I think our biggest ask as industry, because so many of our suppliers and our members are working globally, it's very unique to only sell within the UK or within a certain part of England even, that these requirements can align, because all the different reporting tools and mechanisms and different ways of doing it are incredibly time and resource intensive, and that time could be much better spent actually making the impacts that we want to see.
Fantastic. Thank you, Addy. Ingo, if I come back to you and look at perhaps slightly more specific areas. So obviously, can you expand a little on the role of operating theatre technology in reducing carbon footprints? Some practical examples which perhaps people can adopt to make that little contribution towards improved sustainability.
I mean, the really basic example you've given very early on in the opening, where you said, it goes beyond switching off the lights, but that's actually a really good starting point, because we're looking at energy usage, and Anil has been looking very much into the usage of energy in the operating theatre, and in one of his first trials of reducing the carbon footprint of surgery, it was being proactive in handling the equipment. So that's switching things off, not leaving them on, reducing the air conditioning overnight or over the weekend, things alike, And so we've been looking over the last few years into how can you automate some of these processes, in terms of those menial tasks, automate them, switch things off overnight automatically. When you not use it, switch it back on in the morning. When you come in, automatically, it's all done for you. But beyond that, it's also, as Adi said, the commitment from the supply chain, from the suppliers, to look at how can you optimize and reduce, for instance, components in the overall system design. So looking at the patient itself, you want the best for the patient as a surgeon always. And you also would want the best for the environment to come out. So, so there's a pathway of using the best technology to get the best result. That often, comes with drawbacks on a financial element, where then new technology that does actually reduce the carbon footprint costs a little more money. Where then you have project managers saying, oof, the energy use is not my issue because the electricity bill is paid by someone else. That doesn't come out of my budget. So in a sense, what you were saying before, that the surgeon is, the agent for change. I think that's really important here, that the surgeon, as a permanent fixture in the hospital, can ask for things and drive this change, very much like consumer have, asked Shell when Shell wanted to sink the Brent Spa in the 1990s. And people stopped buying petrol at Shell, and Shell had to change their mind. And the surgeon has power like this to address the industry, to change their ways. Even if you look at the move over the last few years into utilizing more single-use equipment, that was driven because it's comfortable for industry. It's easy to use. In many instances, it doesn't have to be, re-prepared or put through CSSD. And so it's the behavioral change, the acceptance, and the willingness to drive this change as the key opinion leader as a surgeon.
Yeah, I think that's a hugely powerful message, because I've come from a normal day job today, where I've spoken to colleagues who have said, well, what can I do? And we've gone from that to yourself and Anil saying, well, actually, the surgeon is the agent for change, and that's what's going to drive this forward. So rather than feeling, well, it's not really my problem, or there's nothing I can do, actually, you are the focus of it. and center of all this. But so thank you very much. So hopefully that we've got a few questions come through. So I'm going to hand over to Shafi now, and he's going to pass on some of the questions to the panel. Over to you, Shafi.
Thank you. Great. So there's a few questions that come in and we're taken from the top. So I think Jonathan, thanks for contributing. Hope you're well. So he clearly hasn't worked with you, Tim, because he's saying he's not grey yet. So clearly he's being.
I've had a hard life. I've had a hard life.
But he says in the Caribbean, they use reusable gowns and scrubs as standard. And you mentioned earlier, of course, Tim, I think Anil as well, we've gone in cycles. We've gone from using reusables to single disposable and back to reusables. And so the question is, how do we make that stick? In sense that would be a huge cost saving for the NHS. So I think that ties up nicely also to Anil. Anil, you also did the world's first net zero operation, I think, in Solihull, or your team. I'd love to hear more about that and what you think about how do we make some of these things stick into clinical practice.
Okay, good questions. So that net zero operation was at the start of my learning curve. And if I'm honest, it was a fudge of carbon accounting, and it was not a net zero operation. Surgery is going to be carbon heavy. We are always going to be carbon heavy. We are going to be a carbon consumer. And look, some people might not quite grasp this, but we're going to be doing more surgery in the future, not less. Post-COVID, things are opening up. Surgeons, the waiting list, people are beginning to address them. The shift in public health will not be to doing less surgery. It will be doing to more early surgery. Let's fix these hernias. Let's cure these problems. Let's do the early cancers. So number one, always carbon heavy. Drapes and gowns. We are opening a trial called Dragon, which is 26,000 patients randomized to disposable and reusable gowns. So this will be global, UK and beyond. We will put to bed clinical, carbon and cost outcomes. For the first time, we'll have a triad of outcomes we will publish in the primary paper. But it's a bit like electric cars and combustion engine cars. There's always going to be a mixed economy. In Wales, there are no sterilisation facilities. So actually getting things sterilised is really hard. So it's not just a function of surgeon choice. It is a function, as with everything, it's more complicated, isn't it? There's a function of the system behind it. Do you have the sterilisation facilities? Do you have the transport facilities to secure that? Do you have enough gowns in the system? Have you got the payment mechanism to support the sterilisation of the reusable gowns? So we will probably end up in a mixed economy where we will need both setups. I don't think we will change global practice in elective joint replacement, where that group of surgeons will probably always want single-use spacesuits and gowns for the time being. What I would like to see is a shift in the barometer away from where we are now, where there's probably too much choice, there are too many disposables, to wherever possible we use reusable drapes and gowns, and that is a more meaningful, immediate solution.
Thank you for that, and thanks for being honest about the operation you did in 2022, Anil. That's very interesting and very helpful. We seem to have a lot of urologists on this webinar. Tim, must be because of
it's my fan club. They follow me everywhere. I can't get rid of them.
Sure, and I get that. Sunil Sharma is asking, saying, look, we're using disposable flexible ureteroscopes as they are cheaper than reusable flexible ureteroscopes. At BAUS last year, the carbon footprint on reusable was bigger than disposable. So how is carbon footprint calculated in the situation? That's a good question. So how do we actually calculate, actually one of the things, maybe Adi or Lucinda, how do we actually calculate the carbon footprint of a procedure? Any ideas? In fact, anybody can answer that.
I think in answer to that specific question, I don't think any of us can answer it without looking at how it was calculated. There's a lot of different ways.
What sort of things go through your mind? We think about calculations. It's quite a long process, right? You could actually do many things, add up lots of different calculations. But what's the kind of premise? What do we look
at? So we think about, well, it depends on, if you're looking at the carbon footprint of a product, something that we're trying to do in industry at the moment is create a standard around the manufacturing of a medical device to try and make sure there is that level playing field in it, because there is so many different things that are brought into scope. I think energy usage is obviously a massive one. There's the energy that goes into the products in use, the products in manufacturing, the products in travel, to dispose of it, what's some of their end of life, and that's only like some of the aspects that can be included within it. It's a big question, and there's lots of different methods that people use basically. And there's also, when people talk about carbon footprint, sometimes they measure it by spend and using different estimates for that, or they could do it and the bigger picture, more geographical boundaries. So I think it depends on how much they estimated in that when they measure that carbon footprint as well. And it will depend on things like what they use as a sterilization technique, because that can vary massively. So I can't answer that specific question.
It's a difficult one. For people to ask that question, how do you calculate it? How do you go about thinking about what that footprint might look like? One is by carbon credits to overcome some of the burden that you're creating yourself. Another question that's come through is around from anonymous person. Hi, fascinating webinar. Thank you. Do you think medical companies who have vertical integration as a business model and subsequently do everything in-house from the point of raw material to delivery to the hospital will be a good example of how to adapt to sustainability? Ingo, what are you thinking about that?
Well, so there is, of course, we've been over, I think about the last 6-7 years, we've been looking into optimize now on supply chain, from our own energy use, buying in green energy, but also buying components that are recycled. So say, for instance, we buy servers and server chassis that are made from recycled metal. So that's kind of very early on in the supply chain to try and optimize that and minimize the carbon footprint there, and moving on to, as you said, travel. So there's a lot involved in terms of the supply chain optimization and things that you can do, but it varies in terms of the products that you produce. If you're directly involved in surgery and use products that are inpatient or in direct contact in the open surgery or in the patient, then it's different, to compromise there, because the patient safety is the primary driver here.
It's interesting you talk about supply chains. One of the features, if you go on to Surgery International website, is about an orthopedic surgeon, Andrew Dold, and he set up a company in the US which looks at supply chains. And what he realized was some stock was going out of its expiry date in some parts of the country, and other parts of the country were short of certain supplies. And he's matched that. And in other words, if you're running low on some supplies and someone else has got stock which is going to go by its sell-by date, he's arranged this company which can then transfer those goods between hospitals. And what it means is essentially there's much less waste. And again, that's a very practical way of improving sustainability just by improving logistics.
Thanks, Tim, for that. A question from Adam Levick. Could the panel give guidance on what they would recommend as the best route to introduce and demonstrate tangible solutions which reduce the environmental and financial footprint to the NHS as an SME? Really good question. So how do you, it's a difficult question always to answer, of course, how do you penetrate the NHS as an organisation in terms of having a product? Now, Adi, you might be able to help with this in terms of, and also Lucinda, about there might be a startup or an SME, for example, who's got a great idea, but how do they navigate through the NHS, what the opportunity is, and is NHS ready for these companies to come through with the potential solutions?
I think adoption of innovations to the NHS is a huge topic, and there's lots and lots of different ways to do it. I think one of the routes to do it would be your local health innovation network. There's many of them dotted around the country, and they very much work with SMEs and startups to try and get to that point of adoption. In terms of funding, you can look at things like SBRI funding, and particularly they've got a lot going on towards sustainability projects and products. And other than that,
for the ABHI, Adi, you've got a great organisation, and I've been with you for a long time, both Arab Health and other places, and you bring like 200 companies globally to say Arab Health or another conference to disseminate some of their technology innovation. So what's ABHI's role in this? How can you support some of these SMEs come to the UK, for example, and perhaps go more on a global level? What do you reckon?
Yeah, so we do that often, but way slightly from the NHS piece, but the global piece, there's a number of different trade missions and different conferences and exhibitions that we take organisations to, again, trying to promote it. I ask our members all the time to let me know the kinds of things that they are doing so I can use them as case studies to show the NHS what there is and what there is available. There's different conferences across the UK as well that people can exhibit at. Again, Health Innovation Network also do various events and roadshows to try and show what it is that the industry is doing. I think very much our role is to try and support the organisations with our membership and also highlight the good work that they're all doing. And we also try and ensure there's that engagement between the NHS centrally and the members to try and meet in the middle with these sorts of things.
Thank you. Anyway, I feel a hackathon coming along. Are you feeling that same thing? A little hackathon around startups in this space? Because it's an unknown entity, isn't it?
It is, and look, you have to forgive me for a little bit of cynicism here, because part of the problem is supply chains in industry, they are incredibly complicated. It's going to be a slow burner. If you take the major producers, the major carbon contributors to the surgical supply chain, which is why we're here, their whole business models are based around single use. So changing those is going to take decades. Just to get the key partners around the table for a conversation is going to take years, and that'll be behind closed doors. So I'm a little bit cynical there. What I would like to see, what I prefer to see, twofold. What are the easy wins? So there are supply chains around things like food into hospitals that are far easier to win on. At the moment, the supply chain into your local hospital will be by a national supplier, and the food will be coming from many different countries. But I'll bet, if you go a bit further east from where you are, Shafi, you'll find some nice farms out down by the Thames if you just go a little bit further. And so there are probably some relatively easier wins around things like that. But secondly, I would like to see people like us and people like us on this call today advocating for a different type of change. So to take those industry partners, get them around the table and say, well, look, you're not going to change immediately in the next few years. So you need to make a significant financial contribution to the decarbonisation of energy, to the education of surgeons. And I would like to see those companies address it in a slightly different way, in a slightly more global way. I don't think they're going to do that unless we take them there, unless we make the ask. So for Surgery International, there's a challenge back to you, Shafi. I would enjoy to do that with you. I'd enjoy to take an independent platform like yours and challenge these companies to innovate faster in other areas.
And you're welcome to help us, of course, in that journey. Thank you, Anil, for that kind offer. And we may even take you up on it. I'm going to hand over back to Tim. We've only got about a minute left of the webinar. Thank you so much.
Well, I think we're almost there for time. So it's just left to me to thank our panel members. You've all been absolutely fantastic. And I think the take-home message from me is, rather than feeling powerless when it comes to sustainability, the surgeon, as always, is the agent for change. Thank you for everybody else who's joined us on the webinar this evening, especially given that you've all joined us from a variety of locations around the globe. I hope you can join us again next month for our next webinar in our talk series, which will be on digitising the OR, and that'll be on the 18th of April, and again on May 16th for our webinar on surgical leadership. So I hope to see you all again soon. But for now, best wishes to you all, and goodbye.